there a camera on me?
There is-ish, yes, there's a camera on you. It's right in front of you on that little stand.
Okay.
Jason, it says that it's live, but I don't see it live on the, you're good? Okay. Howard, whenever you're ready.
Okay. Zack Loveless is the Director of Programming and Operations at the Hyde Park Institute and a lecturer in Humanities Collegiate Division at the University of Chicago. Zack received his master's in character education from the University of Binghamton and a PhD in philosophy from the University of Chicago. He leads and designs Hyde Park Institute programs in collaboration with University of Chicago faculty and administrators and coordinates measurement of their impact. The collaboration with the Center for Practical Wisdom has been ongoing since 2019 with Hyde Park Institute, and Zack's research focuses on the role that reflection plays in the development and exercise of wisdom and character strengths. His talk today is titled Cultivating Practical Wisdom in Medical Education and is based on our collaboration from 2020 to 2022.
Thank you, Howard. And, oh, I'm sorry, should I have waited? No. Thank you, Howard. Thank you all for being here. So let me just start my little timer to make sure I keep to time. So Howard mentioned that I work for Hyde Park Institute, and I'm just going to say a little word about HPI, as we call it, in case you didn't glean what we do from our very descriptive name. So Hyde Park Institute is an independent nonprofit. We're on the UChicago campus, and we foster the development of character and the virtues in academic, professional, and personal life. So since 2017, we've been collaborating with personnel at the University of Chicago to create programming largely for students, but for the wider community that, help them strengthen their commitment to bettering society and to lead more flourishing lives. So I'm going to talk today about the results of one of the programs we've been running that's a result of such a collaboration with UChicago faculty, specifically to cultivate wisdom for aspiring physicians. So just two notes at the outset. I'm taking medical education in a broad sense to include not just curriculum in medical school, but undergraduate medical education and medical training more broadly. Second, as Howard mentioned, I was trained as a philosopher, not as a scientist. And I mention that not because my results are all philosophical arguments, but you understand why I keep talking about Aristotle and my general level of sass. So let's start with a little context. So medical training is supposed to equip physicians with the knowledge and competence to be able to treat, diagnose, and prevent illness. But physicians are not just technicians. And this is why Dr. William Branch writes, medical education must seek to promote the moral development of its students. Medicine is, after all, a moral profession. Now, this isn't just a peculiar opinion of Dr. Branch, which I share. It's codified in the AMA's Principles of Medical Ethics, which they describe as the standards of conduct that define the essentials of honorable behavior for the physician. Let's just take a look at their first two. One, a physician shall be dedicated to providing competent medical care with compassion and respect for human dignity and rights. A physician shall uphold the standards of professionalism, be honest in all professional interactions, and strive to report physicians deficient in character or competence or engaging in fraud or deception to appropriate entities. So physicians are expected to be compassionate, considerate, respect dignity, to be fair, to respect rights, to be honest, and to be courageous, to be able to report people who are engaging in wrongdoing. So it seems that, at least by their own rights, by their own lights, medicine is a moral profession and thus should nurture the moral development of medical students or its trainees more broadly. But what happens during medical education? The news is not great. There are signs that empathy, moral sensitivity, and moral reasoning all decline as one progresses through medical education. Some things increase, but not the things you want. There's increased symptomology of burnout and moral distress. Burnout itself has been associated with unprofessional behavior. One of the main causes of moral distress is for trainees to witness unprofessional or unethical behavior on the part of their superiors, which they fear reporting because of retaliation. Okay. Well, what can we do to support the ethical development of aspiring physicians? Well, the most common suggestion is to focus on ethical analysis, focus on moral reasoning through ethical analysis of, say, dilemmas. Dilemmas that you might find in a medical ethics textbook, trying to bring philosophical principles to bear on these kinds of dilemmas. However, moral reasoning does not correlate well with moral action. Further, I can't help but notice that the peculiar implication of this is that philosophers tend to be the most ethical because they're the experts in moral reasoning. But I'm going to suppose that someone who is signing up to save other people's lives, perhaps at risk to their own, is probably more ethical than someone who, like me, signed up to teach you shouldn't have killed Socrates, who, for the record, is just standing on the street demanding that passersby give an account of what they're doing with their lives as they just try to get some lunch, okay? And so this is to say nothing about how moral reasoning is going to help us with declines in empathy, increases in burnout, or moral distress. So focus on ethical analysis? No. Okay. What can we do instead? Perhaps we could focus instead on practical wisdom, or as us Aristotelians like to call it, phronesis. We got to let you know, we know this one Greek word. Well, this talk is at the Center for Practical Wisdom, so, phronesis seems like maybe a good idea, yeah? Okay, well, why is that? Well, physicians must gather and interpret evidence from disparate sources to come up with a diagnosis. They have to determine a course of treatment, not only considering the patient's disease, but their context and hopefully their goals of care, and do so in a way that's compassionate, honest, respectful, okay? Well, luckily, phronesis is sensitive, attuning us to the relevant factors in a situation so we can form a coherent interpretation. It's supposed to be integrative, facilitating complex decision-making where we have to balance different viewpoints or different standards. It's contextual. It doesn't just blindly follow general norms, but tailors decisions to the situation in light of those norms. It's ethical. It helps us achieve moral ends and is shaped and guided by our moral aspirations and moral commitments. And lastly, it's connected to flourishing, a state in which all or most aspects of our life are going well. Okay, so it seems that we would do better if we focused instead on wisdom or phronesis. And I'm not alone in recommending that it would be good if, in the context of medicine, we focused on this, but the question is, how? I mean, there's less evidence or less writing about how we could try to cultivate wisdom in medical education. Well, luckily, there's a Scholars in Ethics in Medicine program. Well, good thing you came to this talk, huh? So first, I'm going to describe the aim of this curriculum and kind of the structure of it. And then I'm going to back up, because I can't help myself, and explain how it's informed by some Aristotelian philosophy, as well as some more general principles of character development or character formation. Okay. See if I can keep up this manic pace the whole time. Woof. Okay. SEM. Okay, it aims to prepare students for the challenging situations they will encounter in medicine through discussion of physician experiences with these challenges, okay? I'm going to keep harping on this. I'm just going to keep coming back to this point because I think this is very important. Okay, so it's for a cohort of 25 to 40 pre-medical undergraduates and preclinical medical students who we select via a short application. When we started this program back in 2017, we would have about 25 people. We grew and grew the program. Now we're selecting cohorts of about 40. They participate in an 8-month curriculum that includes 11 to 12 kind of formal group meetings, which consist of 2 seminars. These are day-long meetings divided into 4 sessions that really explore in detail the application of an Aristotelian framework of virtue in the practice of medicine. So some topics might include shared decision or practical wisdom in the context of shared decision making, courage, how courage, honesty, and compassion may contribute to having difficult conversations, and maintaining trust. Second, we have dinner discussions, which center on experiences shared by a practicing physician that involve a challenge or set of challenges the physician faces in their practice, or perhaps just in a life in medicine generally, such as relationships with patients, maintaining compassion, feeling a sense of perfectionism, burnout, And they engage participants in dialogue about how that challenge can be navigated well or badly, and the ways the physician tries to practices they try to develop or things they try to do to navigate it better and better in their own lives. So with rare exceptions, all seminar sessions and all dinner discussions are led by practicing physicians who share their lived experiences with these challenges. Okay? All right, and then lastly, we have social celebratory events. Yes, 3 to 4 events, just focusing on getting to know each other, the horror. Okay, so these introduce participants to the program and each other. They build connection and rapport so we can facilitate discussions of personal importance, and we really just want to celebrate their effort and commitment throughout the program. Again, students are giving their time to do this, and we want to celebrate them for doing so. In addition to these kind of formal program meetings, they receive mentoring from an early career professional, someone who's just like a little further down that same career and life path, who can provide guidance and perspective with respect to upcoming challenges, the students' aspirations, and their goals. And then lastly, we ask them to complete 4 individual reflection assignments that ask them to relate what they've learned to their experiences and to their developing understanding of the clinical encounter. Okay, so on this next slide, I have a timeline of the curriculum. I'm not going to dwell on it long. I do have a QR code at the end in case anyone wants to see these slides, so you can look at it then. But this just gives you an idea of how the program unfolds overall. So in the center, we just have the kind of formal program meetings. So we start with a welcome, have a seminar, dinner discussion. And then at the end, which is something I didn't mention, we have a kind of panel of our mentors, give them a chance to get to know the mentors overall, and really hear different ways people may have come to medicine or wanted to practice medicine. We want to break down the idea that there had to be one way or one reason people want to get into medicine. Okay. All right. So that's the program. Now I'm going to briefly explain the theory that informs the curriculum, which I hope will illuminate some of the program's focus. So, I said I was trained as a philosopher, so I'm going to start with a quote from Aristotle. So, our characteristic activity is achieved in accordance with practical wisdom and virtue of character. For virtue makes the aim right, and practical wisdom the things towards it. I'm probably the only Aristotelian who thinks you should take this at face value, but I'm not going to anger all the philosophers who may be listening. So the basic idea I want you to take away is that virtues of character, things like compassion, honesty, fairness, courage, and practical wisdom are interdependent. Again, practical wisdom is ethical. It helps us realize moral ends. Well, if I'm going to consistently take moral ends into consideration, I have to value them. I'm not going to be very kind or compassionate. I'm not going to think about being kind or compassionate very much if I don't care if you're suffering or need help. So, second, if phronesis is going to issue in moral action, if it's actually going to be effective, I have to have some motivation, some readiness to pursue those ends. To reliably act well in situations of danger, I need some readiness to face it. So practical wisdom needs virtue, okay? Needs virtues of character. And I understand virtue of character as an inclination or readiness of appropriate or admirable response within some sphere of human experience. Inclination, I want us to realize that this is a motivational disposition. Let's not just call it just a disposition. Second, I think maybe this sphere of human experience phrase may be a bit confusing, but that's just to indicate some set of experiences, and here I'm quoting Martha Nussbaum, that figures in more or less any human life, in which more or less any human being will have to make some choices rather than others, and act in some way rather than other. Okay, so we all have experiences with situations that involve what is dangerous, risky, daunting, and that can cause fear, and we need some modicum of courage if we're going to ever face that danger and not just always run away or freeze anytime we face them, okay? Yet these habits in turn need guidance from practical wisdom. I may readily face danger by rushing back into my burning apartment to save my baby, but if my baby is the ham sandwich I was just making, then I'm kind of an idiot. Now, I will say I recently had some pastrami from Green Street Meats, and there probably are some sandwiches that are worth some risks to limb and perhaps even life, but I digress. Okay, so as one develops phronesis or practical wisdom, your moral habits, these kinds of inclinations, are further scrutinized and refined, so they're better actualized, better implemented in particular situations. In light of your overall moral commitments, your overall personal commitments, you could say your overall idea of how you want your life to go. Okay. So we need wisdom to deliberate well about how to balance compassion and honesty in delivering bad news, or how we can show compassion when nothing can be medically done to help a patient. Hence, our focus on developing phronesis through discussion of how to implement various virtues of character in medical practice. All right, I promise, just a little bit more waxing philosophical before we get to the results you all want to hear. So, I've said that SEM focuses on the kind of challenges you face in medicine. So what does that have to do with the implementation of virtue? Well, virtues help us act appropriately in some sphere of human experience, but it's not thought that there's a virtue for every such sphere we could identify, okay? So here I'm quoting Philip Foot, personally my favorite philosopher. So virtues are corrective. Probably not the best word for this, but bear with me. Virtues are corrective, each one standing at a point at which there is some temptation to be resisted or deficiency of motivation to be made good. As Aristotle put it, virtues are about what is difficult for men or humans, okay? So we all have experiences with self-love, like caring for our own good. Yet Foot argues there's no virtue of self-love because you're already attached to your own good. You don't need to overcome some motivation to care about your own good. But you do need to overcome something to care about other people's good. Turns out it's usually, your love of yourself. So virtue is about what is challenging, and it's because of that challenge that we need virtue to act well. So danger and risk often breed fear, which literally just impels you away from the thing that you're afraid of, or if not, to just shut down altogether. And that is why a focus on moral reasoning or ethical analysis is not going to be enough. Okay? Consider that the AMA principles, the American Medical Association's principles, state that a physician must strive to report wrongdoing. But one of the main causes of moral distress, again, is trainees witnessing people commit acts of wrongdoing, particular deception, and feeling afraid to report it. They know what they should do, but that doesn't mean they can face the fear in the situation where they must do it. Okay? Moral reasoning isn't going to save us. I mean, trust me. Philosophers are not the most ethical people. Let's just say that. Okay. So because virtue is about what is difficult, seminars and dinners are organized around challenges that make the delivery of good patient care or just a life in medicine difficult. Okay. So I would say considering how to navigate these challenges better is considering how to better align our responses with our overall conception of how we want our life to go, and thus is a practice in phronesis, okay? So that explains our main focus. Let me just take you through 4 principles which the program relies on, some strategies that are supposed to support character development. Okay. First, we want to engage with relatable role models, because role models not only show us how to act admirably, but they inspire us to do so ourselves. So seminars and dinner discussions are led by practicing physicians who are both committed to the best for their patients, but can reveal, share stories of vulnerability, failure, and struggle with uncertainty. Program mentors share the same commitment. Program staff tries to model good behaviors. We want them to develop an understanding of virtues. We think, it's going to be easier to aim at it if you know where you're going. So by an understanding of virtue, we will include, knowing what a virtue means, but also when it is called for, why it might be important for our lives generally, or the practice of medicine in particular, how it can be exercised, and factors that may help or hinder its exercise in particular cases. So again, physicians share stories that reveal the challenges they face in medicine and lead discussions of how to navigate them well. Should I just speak over that?
I think we're just going to try to turn them.
All right. I can speak louder, don't worry. I can yell right over it. We'll let the people down the hall hear what I'm saying too. So, in addition to this, seminars will assign readings that apply Aristotelian framework of virtue to the context of medicine. And we provide some didactic teaching about virtue, wisdom, shared decision-making, goals of care. Okay. Third, we want them to reflect on their personal experience. So we not only give them reflection assignments, at the beginning of the program, we ask them to reflect on who they consider an exemplary physician as a way to try to articulate what are the virtues that matter for medical practice. And before our closing ceremony, we ask all of them to reflect on what are the key takeaways from the program, what did you get out of it, and ask them to share that with their peers. And lastly, and I would say most importantly, we try to build a community of support. Just as the hidden curriculum may erode otherwise exceptional moral habits, a friendly environment can nourish virtues development, okay? So it provides support and encouragement, a space of shared purpose and value, and it provides the motivation and courage, strength in numbers, to continue progressing towards aspirations in the face of difficulty. So, as I said before, we dedicate several events just solely to getting to know participants, learning about them, developing friendships. But at each event, we devote significant time. I mean, between a fourth to a third of the time, just for socializing, cultivating friendships, and enjoying good food together. Students build relationships with their mentors. Program leaders strive to be warm, welcoming, and responsive to student concerns. And above all else, we just try to create a space where they can pause, take a breath, and relax. Okay, so that's the program. But I assure you, I didn't bring you here just to tell you to trust me that it's working. We did want to investigate the program. So with the Center for Practical Wisdom's help, we've been collecting data on the program, and we think we were doing good, and so our hypothesis was that they would show some gains on measures of wisdom and character. So on this next slide, I've kind of have an overview of things we covered throughout the different years. I'm not really going to dwell on this. You can refer back to it if you want to look at the slides later, but I'm just going to talk through the slides as we go, because I don't really expect you to remember all these acronyms and everything as I go through anyway. That's like probably a ridiculous idea. Okay, so first slide. So here on the left, it's our first year of collecting data. Notice this is not a control group. This is just two versions of the same measure. So this is the situated wise reasoning scale. It gives students like a self-report measure, but it anchors it in a reflection on an interpersonal dilemma. Except this top line, we actually provided a kind of one of these scenarios for them, and the other one, they provided their own scenarios. That's the personal, the one they provided themselves. So what we saw is for the personal scenario from time T1 to T2, from pre to post test, we did see significant gains on their scores of the Swiss scores, excuse me. On the other version, they also increased, but not significantly. So the other measures, they did show increases. None of them were significant, so I'm not reporting them here. But we were very encouraged by this. But we wanted to give another look to what was going on here, see if we could get the same results. We added a control group, collected data for 2 years. So this year we had 17 people just in the group. This one we have 65 in the control, 25 in the experimental group. Now, as I was practicing this, I kept saying experimental for control, so if I just keep messing that up, forgive me. So, in year 2, we saw a similar thing. The SEM group improved significantly from pre to post test, or maybe you want to say near significantly, whereas the control group declined from pre to post test. Not significantly in itself, but what we saw is that at the end, a significant difference between the group at post test. And then again, we gave them a measure of epistemic humility developed by the center here. So the SEM group increased very little. However, the control group declined significantly from pre to post test, and then there was a near significant difference between the two groups at post test, but largely because we saw a big decline, which I don't know, perhaps SEM inoculated against during that year. Notice these are the COVID years, so who knows what's going on. All right. And here on the right, we have the satisfaction with life scale. It's kind of like a global measure of something like subjective well-being, how you're feeling about your life. And really what we saw is just that both groups kind of maintained their levels of well-being. I mean, the control group declined slightly, but not significantly. But there was just a significant difference between the groups at pre and post-test, okay? So, I mean, I was pretty heartened by this, that we saw any kind of movement in the groups was heartening. But the program isn't just focused on wisdom, so we wanted to look at something else besides just their scores on wisdom. So in the next couple years, we started collecting data on some other virtues as well. Also, we started using a different scale of well-being. In part because I'm an Aristotelian, I think well-being is richer than just whether you're satisfied with your life. That's an important part of it, but we think things like having good relationships, having a sense of meaning, all of these things matter to your well-being. Okay, so just to note, this is a acronym. This isn't about civic fairness or it's the comprehensive inventory of virtuous instantiations of character scale, and this is the fairness subscale. Next time I'll write all of that out. So what we saw is the SEM group remained pretty much flat throughout the year. The control group declined, not significantly in itself, but at post-test we saw a significant difference between the two groups. And then similarly for compassion. This is the interpersonal reactivity index, and I know if they call this the empathetic concern subscale, I think it measures compassion, so you can fight me about that later if you would like. The SEM group increased from pre to post-test, whereas we saw the control group decline. Neither of those increases or decreases were significant in themselves, but we saw significant or near significant increase or difference at post-test. And then lastly, two more, a measure of purpose and well-being. Now these are very similar. For both measures, we saw a significant difference between the two groups at pretest. In the SEM group, we saw a near significant increase on both measures from pre to post-test. And then the control group declined, though not in itself significantly. And then we saw a significant difference between the two groups at post-test. And I would say there's a general trend, the general trend you see in these graphs of the SEM group tending to increase or stay flat and the control groups tending to decrease was pretty common across almost all the measures we collected. Okay, so just a little bit more to share with you. So in addition to this quantitative data, we've also been collecting some qualitative data on the program. And I'm going to share a sampling of that with you, kind of organized around a few themes that I think would be relevant. So the first is navigating dilemmas, because that was of concern for people in medical education. And ostensibly, navigating dilemmas should resonate with their improvements in wise reasoning, I would think. So students said that the program challenged me to think a lot more about how to deal with situations where there isn't a perfect solution. That I feel I have a greater understanding of how to approach medical ethics questions given the lectures and discussions that I've been a part of as a member of this program. And again, I feel like I learned so much about different virtues and how to use them within medical practice, and also had a huge exposure to situations which call virtues into question. Okay. Yeah, this is the feel-good part. Yeah, this is where it's like you start to feel good about what you're doing. All right, don't worry, it's gonna crescendo. We're gonna really get up there by the end. So, growth or lifetime learning, thinking that this will indicate either both that they feel like they've grown or at least feel like they've been given tools to continue growing in the future. This course gave me an opportunity to focus on my own personal moral growth, which I've gravely postponed since coming to college. Heartwarming and kind of sad at the same time. Poor kids, not given any time to focus on their growth. 2, I have come to understand virtues as tools that can be constantly sharpened through experiential learning and modeling. And 3, I learned medicine is a lifelong journey and practice, and that even when it's hard, because it will be, it's worth it. And then lastly, around themes of purpose and motivation, thinking that if people have renewed motivation or purpose to pursue medicine, that should, positively correlate with well-being and kind of negatively correlate with symptoms of burnout. The program, where am I? The program allowed me to reflect on who I am as an aspiring physician and how I want to implement the chosen virtues in my future practice with patients. I enjoyed taking a step back from the monotony of studying and looking at the bigger picture. It was also inspiring seeing so many accomplished physicians who have made time in their careers to explore their interests and discuss them in such a dynamic way. This program has given me motivation to work towards building relationships with patients and people in general. And in their own words, they think the program has had a profound impact. So the SEM program absolutely transformed the way I thought about what it means to be a good doctor. This program has been the best decision I've made as a pre-medical student, and it goes on and on. The vulnerable stories from doctors prompted internal reflection has been a transformative factor in my life this year. The program definitely exceeded my expectations in the impact the advice and stories from physicians would have on me, and so on. The dynamic between residents, medical students, and undergraduate students was incredible. SEM has been a transformative part of my pre-medical journey, and the excellent speakers, insightful questions, and fascinating discussions gave me an open framework that I will certainly develop over my training and lifetime as a physician. Okay, that's enough feeling good. Let's wrap this up now. All right, oh, hi, sorry. Okay, key takeaways, key points. What do I want us to remember? One, wisdom and virtue can be intentionally cultivated. This is not the only kind of evidence to suggest this. There are studies by Brew and Aldelt who have good results about this. There's other studies of other character development. It's a very common misconception, I think, in medicine that you have to focus on moral reasoning because you can't develop people's character. I mean, the hidden curriculum seems to deform people's character, but can't do it intentionally in a good way. But yes, you can. Second, students welcome these opportunities. It's not that they don't want them. What we've seen is that they're happy for such opportunities. And third, data point to the program's positive impact on issues that are relevant to the moral development of medical trainees: navigating dilemmas, maintaining compassion or empathy, and symptomology of burnout. Okay. Now, but really what I want you to take away is this. I think this is a program that can be feasibly adapted to other institutions that other people can adopt. So I'm going to mention a few things about it. One, the speakers are largely not experts in wisdom or character. You don't need to be an expert in wisdom or character. You definitely don't need to hire a philosopher to be able to do this. You definitely don't need to hire a philosopher to teach your ethics curriculum in general. So the speakers are not experts in character. Some of them may have thought about some kind of framework to bring to bear on their talk, but we don't care if you use an Aristotelian framework or someone or another one. One of our best speakers, brings Jonathan Haidt's work to try to understand what she's going through in her practice. That's great. That doesn't matter. We care about discussing the challenges you're going to face and how we're going to face them better. Okay. I would also say that at many sessions, a speaker may never say the words virtue or character or wisdom. Okay, so again, you don't need a bunch of character educators to be able to do this work. Second, it's organized around challenges of concern and familiar to physicians. Now, this is a bit repetitive, but the idea is you're already thinking of and wrestling with these issues. Many physicians already care about these things. Students want to be able to discuss these things. So, one, not only do you know about them, but they don't have to be some added things, just another item on your SCUT list that you have to do. They're things that could be integrated into what you're already doing. I mean, there are grand rounds that departments of medicine regularly have, and there's no reason why occasionally some of these can be discussed challenges people face in delivering good patient care and not just technical aspects of delivering care. I would say medical ethics curriculum don't have to be devoted in the same way that they are. I was looking at a few sample syllabi today, and it's very common to spend a week or several weeks on something like organ donation. I doubt that 1 out of 13 physicians do organ transplants, so I don't know that this is actually going to be an issue they will ever face in their practice, and how it could be relevant to their actual moral development. Okay, so that's the program. You can do it. Thanks for listening. That's it. Huh.
We do have time for questions. There is a comment
Hi, Zach. Thanks for the talk. I was wondering a little bit more about the selection into this group that you trained and who the control group was.
Yeah.
Because I think that would be interesting to understand.
Well, what do you want to know about the selection? We asked some questions about what they hope to get out of the program, what they think the program is about, and largely we select.
Do they opt in?
Yes.
Okay,
they have
so
to
these
apply.
are people who want this
Yeah,
training.
we don't, it's not a randomized sample.
So it's not taking pre-med majors or first, second year med students, whoever is in your group, and randomly picking those
No.
to go into this. Okay.
No.
So I think that's kind of important. These are people who are looking for this kind of thing, which is great. But it would be interesting to know, right, if it would have the same effect for those people who didn't opt into the program if it were part of the curriculum more generally. That would be the interesting part. We don't know whether this group was going to, improve in these kinds of ways anyway, as they engage with these materials.
Interesting from a purely scientific perspective. I don't think it would necessarily be interesting to put the people through a program if they didn't want to do it. I'm just saying, I understand what you're saying from, the science of it would be better if we...
Education of it.
So I think Anne's question about the control group becomes critical here. So the control group, so the major result across almost all of these is there's a difference in the groups.
Yeah.
Right? Sometimes that's a bigger difference at the end, but there's a difference in the groups. So who's in the control group?
Yes. I don't think the control group is just pre-med and medical students. So yes, we could select a control group from people who, we could either do people who applied to the program and didn't get in and put them in the control group. We could do it from a selection of the general medical students. True, yes.
And so those two actually those two are different comparisons, right? The people who wanted the program but didn't get in,
Yes.
versus the people who didn't think about the program. And both of those groups, which are slightly different, might look different. You could actually pull out, since you had a very large control group, you could pull out the non-medical students perhaps and still have enough, or at least look at what the trends are in the control group that was pre-med at least.
Yeah. We could definitely start with, we have the people who apply to the group. We could surely in the future reach out to them and see if they would participate in a study as part of the control. Yes, that's definitely a factor I thought of with the control. Sorry, I was more thinking about the randomization of the experimental group. We're not really going to do that because that's kind of not really what we're doing with the program. But
No, but if the SEM group constitutes 1% of the pre-med students who are going on, and they would show these effects anyway over time without the intervention, that would be important to know.
Yeah. No, I'm in agreement with that part. I'm just saying, in terms of completely randomizing the two groups, we would not do that. So it's always going to be a quasi-experimental study.
Other questions?
So someone Andrea from the online audience said that she thought it would be interesting to see if the skills gained help decrease burnout later. Is there any opportunity because we've been doing this since 2019 with you, is there any opportunity to follow up with those students who have since graduated and where they are? Are you able to track them or reach out to them? I think it's an interesting idea, right? So outside of just the impact, the immediate impact of taking your course for the year.
Probably with the most recent groups, yes. We have probably the contact information of all of them. And so we could reach out in the future and see if they would, for instance, complete a study. But again, my expertise is not on the design of the study. We have a study because of the Center for Practical Wisdom. I help there be a program. So I can answer some of these study questions, but I'm not really, I'm gonna have to defer to some other people about that. But yes, I think we could, and I mean, we can definitely start getting the information. I mean, there's no reason we can't think about that as a future direction of the study, to collect further data after they leave and see, you know, is there any staying power of even the effects they do have? Or is it just they're happy during the program and, you know, then they leave and everything returns back to normal?
Or whether that predicts success. Do they complete their medical training?
Mm-hmm.
Do they get board certified? So even without addressing questions about the staying power of the measures at the time, it would be interesting to know if for the pre-meds in the control and the SEM group, if they're more likely to complete their medical training or go on to specialization.
Yeah, I mean, I think that's a good idea to see like what's happening into the future, because it's also true that really the third year of medical school seems to be the worst. So to see if it's having any inoculation effects as they go through their third year in medical school would probably be to the medical community the most interesting.
These are not statistical questions. I was struck both in your comments and in the comments by the students who had gone through the program about the significance of discussion of specific physicians' experiences, or what at one point you called lived experience.
Mm-hmm.
And I can see that and I can imagine it, because in some ways a person who hasn't heard those experiences might imagine that to be a physician is an impersonal enterprise. You diagnose something, you perform an operation, or diagnose that a medication is required, and you send them a bill, and that's it.
Yeah.
I'm guessing that when they hear these lived experiences, that one of the things that emerges is that these are human relationships. They've got a personal dimension. There's a stake on the part of the physician in the outcome that goes beyond simply checking off, okay, they're taking 2 aspirin a day or whatever it is. So that I'd like to hear question 1 about what was the power of the physician's experiences as you saw them being appropriated by the students. What did it enlarge in their perspective about what this vocation involves?
Mm-hmm.
Second, and I think somewhat related question, is what I'm going to take to be a metaphor, burnout. We're not talking literally here. We're talking, yeah. Ooh. We're talking about someone who simply no longer has the impetus to continue. This job has overwhelmed in some way, so that the future has become dark for that person. And I'd wonder if you could talk a little bit, as you've listened to the physicians themselves and to the students who've been involved in the program, about the power of the future that protects against burnout, and that also, I would think, enriches the idea of the physician's moral experience or ethical experience.
Okay, I'll try to answer those questions. I'll take your first one first. I think what I would say is 2 things. Well, we'll see. We'll see how many things I end up saying. One, I think they get a lot from hearing there are these physicians who, by all accounts, are succeeding in their jobs. You know, they have a position at some, you know, they're a faculty physician somewhere. Great. I mean, that's where they want to be. And one, they hear them really trying to care for their patients. They hear them struggling to do so. And I mean, that may sound like a bad thing, but actually, I think hearing that those people struggle and then still succeed is like the heartening part of it. That I think there's a tendency to think like you can't have ever failed, you couldn't have ever done anything wrong, you have to follow this exact path to get where you're going. And I think seeing these different physicians show them that that's not the case. I mean, this year, the person who talked about perfectionism has talked about how her brother, like she came from an immigrant family. Both her brother and sister succeeded in medicine, got into the top medical schools. The first round, she didn't get in. Then she didn't pass her most important exam in like the second year of med school. And I mean, think about telling these students, it's like, you know that exam you're worried about? I failed it the first time. I mean, that was, I think, heartening for them, like encouraging that it's like, it's all okay. At our mentor panel, there was a similar idea. The advice someone gave was like, well, I'm just going to quote the Big Lebowski. Nothing is, here, dude, like everything is okay. Nothing is messed up yet. Like, don't, and I think this message is part of what's encouraging for them to hear. I think also, though, we focus on talking about their experience of these because I think there's a tendency, especially when you have a philosophical influence, to pick out these dilemmas that are a bit manufactured, that don't really represent your lived experience or your experience with those challenges. They're a little bit too clean, like we have a choice between this or this. And I don't think that's really how the things end up playing out a lot of the times in real life. So I think it's helpful to hear the way people are struggling with decisions in actual life and not just like, oh, should I respect autonomy or should I, you know. Okay, the second question. Can you remind me a little bit? So like how it may,
Well, I guess
like it will hearten.
How cultivating a sense of how the process of a student and a physician cultivating a sense of the breadth of ethical responsibility in the relationship with not just 104 patients, but this patient, and what is going to happen to her as I work with her to make decisions that are crucial for her life that I'm involved in. How do I keep both distance from that in order to give a step back distance perspective and assessment? And how do I engage this person who is a fellow human with me? Mm-hmm. That is a huge amount of stress, I would think, of being a physician. And that led me then to the question of burnout and the way in which taking up this set of ethical obligations, in fact, although you might think they contribute to burnout, I suspect that in some ways they are what give a sense of who you are that protects against burnout.
Yes, I think the last thing you're saying, I'm going to agree in broad outline that I think a lot of the times, well, there's a question of like how much of burnout is moral distress, how much these two things kind of go together. I mean, people sometimes talk about moral injury. I don't know that. I mean, I don't know that literature that well, so I can't say that much about it. But I think, yes, I mean, a lot of the times ethical principles end up, may undermine well-being when you can't actually act on them, when you feel that things are keeping you from being able to realize them. And I think that's a lot of the worry that medicine is going to keep you from practicing in the way that you want. So I think part of what is, helpful about this program is students hear people saying, these physicians aren't like saying, no, it's not a struggle, it's all roses out there, don't worry, it's going to be great. I mean, they say it's hard. I mean, it's not easy. There's no easy solution. That's another thing. We don't have there's no technique you can do to make this all better. If there were, someone would have patented it and, be selling it for lots of money. So I think they see that these people are still making it and trying to live up to their principles. Yes, it's going to be difficult, and they see that there are other people who want the same thing as them, that they're not really alone in wanting to go for that. So,
In the narratives that the physicians shared about their experiences, did they share experiences of their own or an observed moral failure or ethical dilemma?
Oh yeah. Well, I mean, that person didn't have a moral. Failing a test isn't a moral failure. But there have been, there's one physician who talks about a case where, she's seeing a patient. The patient gets a diagnosis that's probably going to be fatal. And the patient, like it indicated before, it's like, well, if the test indicates that I'm going to get this diagnosis, well, I have guns at home. I know how to take care of this. And well, when she got the result, and it seemed to indicate that, well, there was like, maybe there could have been something else, but, then her worry like creeped in, and it was like, I suggested it could have been something else. But it wasn't. And what the person didn't want to happen is what ended up happening. So yeah, they do share those stories. Or they share stories of like just immense personal loss and like having to go about their day while this is going on. Or, yeah.
Have you given any of the physicians the Swiss or any of the measures?
No, I haven't. Do you think that's something we should do?
It might be interesting at least to think about something like the Berlin paradigm. The question would be if you could establish that some of the physicians, right now you're sort of saying sharing personal stories is what's important. And the reason I asked the question about moral failure is maybe some of the stories may be differentially effective in respect of the goals of the program.
Mm-hmm.
And some of the ways in which those stories are related might be differentially effective. And so it might be, if Loris Kaljan and other people who have taught wisdom in medicine were giving their personal failures, they would have a different perspective on how to relate it based on their experience in the classroom. That might be differentially effective or not.
Mm-hmm.
I don't know. It would be an interesting question.
Yeah, I guess the reason I tend to focus on challenges is just because I think that's a way you can talk about virtue without being a virtue ethicist. Like, people know how to talk about challenges they face and what I think gets in the way of them trying to realize what they want from their lives. And so that's why I think that's important. Sorry, go ahead.
Oh, I was just wondering if the physicians that and the mentors improve over the course of the year. So the act of going through reasoning with somebody who's more junior to you may have a help with burnout and may also help with wisdom and reflection on those. And so I'm wondering if that would be an interesting thing to see, how the sharing of those and the impetus to be in the program itself might increase wisdom. I don't know.
Yeah, we haven't looked at any data from the mentors, so that's another thing we could potentially look at. The mentors, at least some of them are former participants. So if they were a medical student in the program, we asked them to come back as fourth year and act as a mentor. But it's not like they would have just taken all the measures, and the measures might not even be the same by the time they take it anyway.
That would be all of our questions. Thank you, Zach.
Thank you. All right, time to be unprofessional now.